Okay. Well, welcome back. And we'll continue talking through the morning, talking about assessment strategies that you might consider using when you're working with people who have, or children, adolescents who have social phobia. And then the fourth part will be about existing treatment strategies, some background for why we developed social effectiveness therapy in the way that we did, and I'm going to share with you the outcome of a series of studies that we've done to validate the procedure. And then we'll spend this afternoon talking specifically about how to implement the intervention and have some opportunities to do or observe some role plays, build some hierarchies for children, talk about homework assignments, and talk about the nuts and bolts. Okay. So again, when we're talking about assessment strategies, there's a number that I recommend. And one of the most important is a diagnostic interview. And the recommendation is there's something called the Anxiety Disorders Interview Schedule for children and adolescents that is a very good diagnostic interview. It's a semi-structured interview, but it really goes through the social phobia section in very good detail and also helps you rule out or determine whether the child in front of you really has social phobia or a different anxiety disorder or a non-anxiety disorder. And I think understanding this again is crucial because we've often had, particularly if you're promoting a program that has a lot of social skills training in it, lots of people know children who have problems with social interactions and who we think need social skills. But not everybody who has social skills deficits has the same social skills deficit problem, right? A very clear example is if you think about children with attention deficit disorder and hyperactivity, certainly they have difficulty in peer situations. Certainly they have social skills deficits because they bust into a group. They say, you know, I want to play. They take the ball. They change the rules. They get all the other children mad at them. Well, yes, they need to learn social skills, but it's very different social skills than children with social phobia who are standing off in the corner, who don't know how to come into a group, don't know how to engage. And again, if we think about this disorder, specifically if we think about it in children, what we understand is that these children from a very, very early age isolate themselves, don't interact with other kids. So if you think about what do these kids need? When these kids say, I don't know how to interact with other people, yes, they probably don't, because they haven't learned how to interact with other people in the way that we do. So we don't go to social skills classes. I mean, that's not in any school curriculum, social skills, group. But we learn how to be skilled or how to be better skilled by interacting with other people and getting feedback. So if we do something stupid, someone tells us, right? They're like, well, that was really dumb. Don't say that to me. That hurt my feelings. But if you've never had those opportunities because you're over hiding in the corner, you never have the chance to develop those skills. So doing a good, thorough diagnosis and not just assuming that someone who is socially awkward has social phobia is clearly very important. And we see it again when we talk about kids on the autism spectrum, right? Kids on the autism spectrum often don't have difficulties going up and talking to other people, but they have difficulties in the content of their conversations, and they don't understand why everyone else doesn't want to talk about dinosaurs of the Jurassic period or, famous generals in the Civil War. And they can't understand. They have restricted areas because that's part of their disorder, but they don't understand why other people don't want to spend hours engaged in that type of conversation. Again, in need of social skills training, another example is a little guy on the spectrum that we talked to who, the other kids at school said, well, I'll be your friend if you lick the floor. Okay, so he wanted friends so desperately he licked the floor. Well, of course, they didn't become his friends. They just laughed at him, and then his nickname was Floor Licker. So the idea that we have to teach them social skills, we have to teach them what friends are, what friends do and what friends don't do, but again, very different. So my caution is always that make sure before implementing any program that you have the right diagnostic condition and that you're giving the right treatment for that particular disorder, because otherwise you're just giving an ineffective treatment, and that's not what we're all about. So the really nice thing about the anxiety disorders interview schedule is not only for children and parents, is not only does it get you to ask all the right questions, but in the social phobia section, it gives you a whole list of different situations. So do you have trouble starting a conversation? Do you have trouble maintaining a conversation? Is it hard for you to get up and talk in front of the group? Do you get nervous in the hallways? Do you get nervous when you join a group? And all of that is such rich clinical information that's going to help you this afternoon, and also as you go along in really developing a treatment program for the specific child with whom you are working. So rather than just, I'm going to take this canned program and slap it on this kid, to be able to tweak and modify that program so it really is relevant for that particular child. So it's often, we all want to do treatment, and we often, want to rush in and help somebody, but stepping back and doing a real thorough diagnostic interview to make sure that you're actually giving the right treatment is crucially important. So, another thing that you'll see and that we'll talk about as we go through some of the data are really severity ratings as well, right? So people can be kind of socially phobic or may, barely meet criteria, but they may not have a lot of impairment, or they may be really severely impaired. So, and again, it may be situationally specific. So I personally don't like snakes, okay? But then my idea of camping is I have to stay at a Holiday Inn. So I'm not, going to be going out in the woods and in a tent where snakes might be, because to me, I don't understand that. That's not fun. So do I have a snake phobia? Yeah, probably not, because it doesn't interfere. It doesn't prevent me from doing things I want to do. So again, looking at the clinician ratings and the ADIS in the diagnostic interview, it allows you to make a rating of severity. Is this child moderately impaired, so they go to school but they don't have a lot of friends, or is this child so severely impaired that they don't even get to school? So when you're evaluating the literature and looking at outcomes, looking at those specific criteria and how a child might change from before to after treatment may be significantly important, because we often know, that the goal is, or at least my goal is, I don't want children to learn to cope with their fear. I want to make their fear go away. I'm just stubborn like that. So I want the fear to go away. But in some cases, we may have a case where they may never be totally, completely free of their anxiety, and the best we can do is get it to a point, at least with the treatments we have right now, is get it to a point where it is easier for them to interact. They have a couple friends. They may not ever be the most popular kid in school, but now they've got a few friends and they're feeling happier. So using the severity ratings and also what's called the Children's Global Assessment Scale. The Children's Global Assessment Scale is a scale of severity of overall functional impairment. So it really can help guide you, and you'll see it in some of the graphs that I'm going to show you a little bit later. Scores of 8 or 9 indicate children who are functioning really well in all aspects of their life. Scores of 4 or 5 or 40 or 50, depending on which version of the scale you have, really are talking about kids who have pretty moderate to getting towards severe impairment. So, and it's across all areas of their lives. It's not that they just can't give a speech, but it's affecting all those areas. So using those instruments, both in evaluating them when you're looking at the published literature, but also when you're working with children, can be significantly important in helping you be a well-informed clinician in working with children. These other scales might also be helpful. There is one called the loneliness scale, and someone, when I was being interviewed, once asked me, what was the thing that occurred, that I found through a lot of the research that I did with kids with social phobia that I never really expected. And what it really was is how lonely these kids really feel. I mean, we don't really think about it because they're kind of quiet, they're sitting there, you know, they don't come in for treatment. I've only ever had one little guy who dragged his mom in for treatment because he had heard about our program and he said he was too shy. And she kept saying, oh, you're not too shy. And he kept saying, Mom, I am too shy. And he was right. You know, he clearly met diagnostic criteria, didn't have any friends. But what struck me when I really started to work with children and adolescents was just the real loneliness that they feel. They know they're different from the other kids. The boys will try and hide it, and because the boys will say, well, there's a part of the interview that says, well, do you have friends? Well, who are your friends? And so, and the boys will sometimes saying Scott and Jimmy, and Mom's in the background going, you don't know anybody named Scott. You know, they're kind of making up these names because they don't want people to know how this has really affected them. They know they're different. They try and hide it. And so the idea of how lonely these kids really are was really something that was striking to me. So there is a scale called the loneliness scale that you can look at, and it sort of, you know, can help you figure out as you're going through treatment, you know, are these kids making friends? Are they feeling less lonely? Yes?
Not so much for research because it's not normal, but clinically, what do you think about the scare?
I think that's a good instrument. I mean, and I think there's some that are better, but I think that's a good one to use as well. So it's shorter than some of the others, and that's always helpful. I think that, you know, in some cases, some of the instruments that have been developed, like the one that I developed, we try to develop it to help inform treatment as well as to just be a screening instrument. The SCARE to me is a really good screening instrument, but there are some that I think are better at sort of targeting exactly what the specific problem might be. But I think as a general screening instrument, it's fine to use. So.
I'll be right back. So why don't you take questions in the meantime?
Okay, so we'll just hang out, take some questions. So, yes?
You mentioned, obviously, to figure out what exactly is like primarily interfering. So when you get children or adolescents who are, you know, comorbid with, for example, like social phobia and depression, how do you determine that they're like appropriate for your program as opposed to something that specifically targets depression?
Right. I think that's a couple of different ways, and I think that's difficult. I mean, in some cases, I often, and I'm not sure this is right, this is just the way I do it, I often think about primary in terms of what came first. So if the parents say, you know, look, even from when they were a little kid, they ran away from other people, hid from grandma in the house, you know, they were a happy baby, but when people would come around, it was like all of a sudden I had a different child, you know, but lately I've been noticing that they've been feeling more sad and they've been crying for no reason. So, I mean, in some cases I look at what's the primary disorder in terms of which came first, but you do have to sometimes figure out if the depression is so severe, can they really participate in the treatment program? Because we know, for example, and the data show with adults who have obsessive compulsive disorder, for example, that if you try and do exposure therapy with adults who are severely depressed, even if they do have OCD, they don't habituate. Okay, because for some reason the depression seems to be interfering with the ability of the neurons to make new connections, which is now one of the ways we know that exposure therapy works. So I think in some cases people may be so depressed that, you know, they can't come to sessions, they can't participate, and they're certainly not going to do their homework. So in those cases, even if the social phobia was the first disorder that occurred in their life, the depression may need to be treated. We usually refer them to a psychiatrist and get on some medication so that then we can do the behavior therapy and then we can take the medication away. Because, I mean, I've had, again, adolescents or adults when I've said, well, you know, what do you think is more important? You know, your social anxiety problems or your sadness? And they'll say, well, if you didn't have any friends, wouldn't you be sad? You know, and to me, they're kind of saying that the sadness is as a result of their limited social interactions. Now, that's their perception, but we go with it. So that's the only thing that I think, you know, I can say. It's really sort of on an individual basis. But obviously, if kids are cutting or they have suicidal ideation or, you know, they're not eating or they're not getting out of bed, then obviously that's something that really needs some treatment. So. You guys have any thoughts on that, Wendy? Yeah. So, yeah. I mean, I think, you know, it's always funny, and I think with some of these diagnostic instruments, you still have to use your clinical head, right? Because you can, kids can meet criteria for almost everything, you know, and then you have a kid who has like 5 diagnoses, and, you know, is that really helpful? So, but, you know, if you think about, you know, how do I put this together, and, you know, is the social phobia different, or does mom talk about, you know, I can't get this kid off my leg, and you think, oh, the kid has separation anxiety, but maybe it's only in situations where there are other people. You know, so I mean, if you think about the old Freudian interpretation, you know, we talk about kids with separation anxiety not being able to detach from their object. But I often think in those little kids, maybe they're just like clinging to something familiar because the unfamiliar is too scary. So, which would argue for a different way of conceptualizing that particular disorder. So I think a lot of it, and we're going to get into the cognitions in a minute, and I'll try not to get too far along on my rants, but I sometimes think that, you know, one of the problems, and since I've been sort of both in both camps, in the adult and the child part, what I see a lot of is you see there's an adult intervention, and then it's kind of like jammed on the kids. So you'll often see these sort of interventions that were developed with adults with not a lot of thought about whether that makes sense for a 5-year-old, for example. So, I mean, and, you know, I've seen in some of my reviews that we do for different agencies that people are talking about, you know, changing cognitions in a 4-year-old. And, you know, I mean, sometimes it's a little hard to do that because, you know, most of the 4-year-olds I've talked to or 5-year-olds, when I say, well, what were you thinking when you were in that situation? They say, I was scared. And they say, well, no, that's a feeling, honey. What were you thinking? I was just scared. So, you know, I mean, are they not able to verbalize it? Maybe they have the thought and they're not able to verbalize it, or maybe at that age, we know that metacognition, thinking about thinking, occurs later on. So maybe it's wrong at that point to be thinking about it, and we just need to use, as I know you've been taught down here at FIU, and as I know people like Dr. Phil Kendall have talked about, is being flexible with all of our manuals and thinking about where we are developmentally with people before we start to just put a treatment onto them. So, okay. So back to self-report, and we were talking about the loneliness scale. The Eysenck Personality Questionnaire is another one that kind of looks more at temperament than at specific diagnoses. But it can help you look at kids who are behaviorally inhibited, who may be more on the introversion side than extroversion, and so it could be useful. The Social Phobia and Anxiety Inventory for Children is the one that, you know, in full disclosure, is the one that I've developed for a number of years with Sam Turner and Tracy Morris at West Virginia and some other people that we use to assess, not only for research purposes to look at social phobia, but it also helps look at sub-questions that talk about, are these with people I know, with people I don't know, only with adults. So it gives you sort of, again, an idea of looking at not only a total score, but looking specifically at what might be the areas of treatment. You know, maybe this kid is okay with familiar peers, but has real trouble with unfamiliar peers, and so that's where I have to focus my intervention. So again, it's not as short as I would like it to be, but does seem to be helpful. And then there's also John March's measure, the multidimensional anxiety scale for children, which looks at different anxiety disorders rather than mine, which is more specifically looking at social phobia. Again, they're kind of quick to give. You can give you a broad indicator. Again, once again, I never, ever recommend that you do a diagnosis based on scores on self-report inventory, because they can certainly be false. There's always false positive rates, false negative rates. So you always want to be careful when you're doing it, that you follow it up. If you have a suspicion, that you follow it up with some sort of diagnostic interview, either a clinical interview or a structured interview. As far as the parent side goes, we don't have a lot of good instruments to look at specifically social phobia in the parent. The one most commonly used is the child behavior checklist. That really looks at a lot of internalizing and externalizing behaviors, can give you some idea of social competence. So it might be helpful in looking at what a child does, how effective they are in different situations. And then finally, we do behavioral assessments. And I'm going to talk about the behavioral assessments for a minute, because in the data that I'm going to present, we'll be talking about the role plays and the reading in front of groups. So before I discovered the we did what most people did to assess social skills in children, was we had them engage in a series of little vignettes where we brought in a typically developing child, a child with no disorder, who would come in and be a role play peer. Because again, you know, a child interacting with an adult, I mean, what does that really tell us? Nothing. So, but if we brought them in and had them interact with the same age peer, we thought we might get a better idea of their skills in that situation. So we have a cadre, I guess is the best way to put it, of typically developing peers who assist our clinic in a number of different activities. They get a little bit of money when they come in and work as a peer for an afternoon, doing some assessments with kids with social phobia or playing the Wii, whatever it might be. But basically, we set up a little situation, like we say, okay, with the child with social phobia, we want you to imagine that you're standing in your front yard and another kid is riding by on his bicycle and he has a crash with his bike, and his bike is wrecked, and he says, how am I going to get my darn bike home? Okay, and so then we want the child with social phobia to respond to that situation. So what does the child say? Do they say nothing? Do they say, too bad? Do they say, you can use my phone? Do they say, my mom will drive you home? What is it that they say? And then the child has another prompt, which is usually something like, maybe I should call my dad. And so then if it gets awkward sometimes, because if the kid with social phobia does say, you know, maybe you should call your dad, and then the prompt is, maybe I should call my dad, it's kind of weird. But we have 5 situations like that where we're looking at things like starting a conversation, giving a compliment, receiving a compliment, being assertive. So in one of the scenes, the bully takes their comic book or their magazine if they're an adolescent. And by the way, all my scenes, my adolescent peers told me that they had to rewrite all of my scenes because I wasn't saying the right stuff in the prompts that I'd given them. So the adolescents kindly and thankfully rewrote them so that they were adolescent talk. So we have 5 of those that we use in these situations. And basically, again, before we had the fancy Noldus observational system that we have now, where we can look at really discrete behaviors, we were basically doing ratings such as, did they make eye contact? Overall, did they look anxious? Overall, were they skilled in the interaction? And we had undergraduates who did not know which kids had social phobia and which were our normal control peers, because we always have the normal control peers do it as well to kind of keep people blinded. Look and rate these behaviors: anxiety, skill, latency to respond. So if you're familiar with Jerome Kagan's work on behavioral inhibition and latency, he's found that one of the best indicators of inhibited temperament is the length of time that it takes someone to respond to a prompt, as well as the length of time it takes them to make a spontaneous comment. So we look at those things in the interaction. So there's just very brief, short interactions. And so that kind of looks at their general social skill. The other thing we wanted to do was look at their ability to do a performance. So again, if we think about social phobia as partly social interactions and partly performance situations, we were thinking, well, what kind of a performance situation? Because kids don't give speeches. So, but we said, well, kids have to get up and read in front of the class. So the second part of the situation is we have them we give them a book. It's been Jack and the Beanstalk for many years because I don't know why we just picked Jack and the Beanstalk. And we have them read in front of a small audience, usually 3 people, and for 10 minutes. And so what we want to see is A, do they read? And B, how do they read? So do they read softly or loudly? May I borrow your book for just a second? So what we find is, which is not always captured, is that a lot of kids with social phobia will go, Jack lived in his house with his mother, and will read with the book in front of their face if they read at all. It's a picture book, so there's lots of very cool pictures. Kids with no disorder will go, Jack lived with his mother in a small house by the edge of the forest. Okay. Jack had a cow, and Jack had to take the cow to market. Okay, so thank you. It's a very different performance of reading of Jack and the Beanstalk. And for adolescents, we have a little bit higher level book than Jack and the Beanstalk. But this idea that you can look at the efficacy or the effectiveness of reading in front of a group, which looks very, very different in different groups of children. So, and again, we do the same things. We rate skill, we rate anxiety, we rate do they even read. We also rate do they quit. Okay, so if the kids just can't read for 10 minutes, they start to cry, we don't let them cry for 10 minutes. We stop it and say, that's good, that's why you're here, because we're going to make you better at doing that. And so we can also time how long they can read. So in this series of studies, and looking at different levels of skill and anxiety, what we find is that in this role play task, of course, these are our blinded raters. Our scale goes from 1, which is absolutely no skill, okay, up to 5, which is, wow, this kid is the most skilled kid we've ever seen in our lives. What you see is that the blinded raters can clearly pick out the kids who don't have skill and who have a lot of anxiety. And those are, of course, the kids with social phobia as opposed to our typically developing or normal control children. The same thing in the read aloud task. So the kids with social phobia have less skill and they have more anxiety than children who don't have any disorders. So some gross measures of behavior to be sure, but at least some things that we can feel confident that self-report is correlating with their actual behavior in these different situations. And as you can see, when we recruit these peers, and I'll probably say this a couple more times today, but we're not looking for the most popular kid in the school or the big man or big woman on campus. What we're looking for is just sort of the average type of child. So we don't want people who are super, super skilled because that's not reality. So we're trying to get a benchmark of kids who just seem, kind of typical. They've got friends, they do things at school. So, and we'll talk a little more this afternoon about where we get them. So, right. And the same thing with adolescents, although you see that the scores are not quite as different as they are in young children. And again, I'm not sure if this is the nature of the task, which I said can be pretty artificial. But we do see that kids with social phobia, if you remember, the children had a 1.9, this is a 2.4. So a little bit more skill in adolescent than in young children, and maybe a little bit less anxiety, but I'm still not sure, like I said, if that's due to the task or due to actual developmental changes in the way people behave. So, all right. And then again, if you just put them side by side, and this is a little bigger sample, but if you put them side by side, you can see speech latency goes down in adolescents, so they respond more quickly. They show a little bit more skill. So these are both groups of social phobia, of children with social phobia and adolescents with social phobia. So they have shorter speech latency, a little more skill, a little less anxiety in those situations. So maybe something's happening. Maybe they're getting a tiny bit more skilled in that task, at least as they're older. So, all right. So negative cognitions, and a lot of people, when I present my treatment program, they say, well, you don't do anything to change cognitions. And I go, yeah, I don't, because we were talking at dinner last night about in academics, the relationships. So somebody who's your student becomes your daughter or your son or your granddaughter or your grandson. And if I go back, my learning, I'm then a granddaughter of Skinner in terms of my learning theory, because my learning, my graduate mentor, who taught my learning theory class, he wasn't my entire graduate mentor, but taught the learning theory, was actually a student of Skinner's. So in that case, I'm probably much more behaviorally rabid than some other people. But when we think about negative cognitions, we do think about these thoughts or expectations that are part of the clinical presentation and whether or not that they exist in children. And so for her, for one of her studies, again, another graduate of FIU and another student of Dr. Silverman is Candace Alfano, who did a study in our clinic where she was looking at the assessment of performance expectations. So what did kids think were going to happen in these situations, their actual performance, and their actual thoughts during these interactions and a read aloud task. And so what she did was she actually got a camera. We did this cognitive assessment strategy where what you do is, so if someone later wants to ask me what I was thinking while I was talking to all of you, there would be a camera placed behind my head, which would really have the view of you. So when I was then reviewing my thoughts, I could be looking at you. And if my graduate student is yawning, you know, I might be thinking, oh gosh, I must be boring because, you know, look at that person yawning. Or I could think, oh, he stayed up too late last night and that's why he's yawning. So you can have different thoughts about the same situation. But the idea is, in this study, she actually had this camera and then sat down with the child after they did the interactions and asked them what they were thinking. So she had their ratings beforehand. What do you think you're going to do? Their actual ratings, and then their actual thoughts. And what she found was that children with social phobia did predict and evaluate their performance as being poorer than kids who had no disorder. So they predicted that they were going to do less well in the interaction, and they felt afterwards, they thought or perceived that they did less well in the interaction. However, their negative judgments were actually accurate because the independent evaluators saw them as being less skilled. So the idea is that it's not that they have these negative thoughts that aren't true. They were actually accurate. They said, I'm not going to do very well in this task. And the independent evaluator said, well, that kid didn't do very well during this task. And it turned out to be the same kids. So they did have these sort of negative perceptions, but they were actually correct perceptions. So correctly negative perceptions. But the interesting thing was when we looked at what were you actually thinking, we got this very frustrated little kids who kept saying, I was just nervous. I wasn't thinking anything, I was just nervous. And so it was only in adolescence that adolescents actually started thinking, I thought those people, or said, I thought those people thought I was stupid, or I thought I was sounding very stupid. But so it was only in the adolescent group that we found any evidence of negative cognitions, and only, quite frankly, among 20% of those adolescents did they report any negative thoughts during the actual situation. Now, that doesn't mean that they might not have negative thoughts later. They certainly might. One of the things that when you really talk to people who have social phobia, they'll often say, I was so overwhelmed by anxiety, I couldn't think of anything. So they will often say, I couldn't, or I was so busy trying to construct the perfect response to what somebody was saying to me, by the time it was my turn to talk, I didn't even know what the conversation was about anymore. So this idea of sort of internally focused attention, but also that they're not actually during the interaction going, gosh, these people think I'm stupid, these people really think I'm stupid. They don't seem to have those thoughts. And when they do, at least among adolescents, they're only occurring in about 20% of adolescents, and we just didn't find any evidence of them in children who were age 12 or younger in this particular study. So, and these were the kinds of thoughts that we were rating. I can't do this. I wonder how I did. This is a stupid task. This happened to me once before, and just I felt nervous. So those were the kinds of thoughts that they had. And so in this second study, what she was actually doing was, again, look, maybe these slides are out of order, I'm not sure, but looking at these children, this was the particular sample. So 50 children with social phobia and 30 normal controls. 48% were female, and some children, mostly Caucasian and some African American, and those same two tasks. So using this video-mediated recall procedure that I talked about before and looking at those different types of tasks. So when we look at controls and social phobics as opposed to just social phobics, children and adolescents, again, what we find is that the negative performance tasks are only in children with social phobia, but children who are typically developing normal controls have a lot of neutral task thoughts. So it's like, oh yeah, this happened to me before. Oh yeah, I remember reading this story before. So they do having some cognitions. And even children with social phobia are having some negative thoughts, but these are averages. So you're talking about a small percentage. And when you look at this, you're talking about like 0.2 thought, which meant that among 5 kids, 1 kid had a thought. So you're looking at very small levels of negative performance cognitions in children with social phobia. And then the same expectations with social phobics and normal controls, that they expect to perform more poorly, they do perform more poorly, and in both the social performance role play tasks and the read aloud tasks. So the situation doesn't matter. They have these expectations and do in fact perform more poorly. And as I said, we're rated more poorly in the interactions, both in the role play and in the read aloud task. So, and of course had much longer speech latency. So some clearly significant differences between the two groups and between the adolescents and the younger children. So, which again you see there. So.